loud and clear? Somebody to confirm that you can hear me?
Yes, Kennedy, loud and clear. Thank you.
Great. It's my honor and pleasure to have all of you here. I know there are some that are still coming to join. So I feel because of time, we can start. Then, of course, we are recording the session, so it will be also a good opportunity for those who have missed the first session to have a time to listen to the recording, and also for you who have already joined. It is usually my privilege to discuss matters cancer, and every moment I get, I make sure that I create awareness out there. So for some that might not know me, my name is Kennedy Okinda. I'm a nutritionist. I've specialized in cancer treatment. So I'm an oncology nutrition specialist registered by Kenya Nutritionist and Dietetics Institute. Apart from my background in nutrition, I'm also a research officer, having led research and programs unit of Moi Kibaki Referral Hospital for close to 4 years. I've published in a high-end journal. So far, I have 6 publications. And currently, I'm serving as a resource mobilization and partnership manager at Moi Kibaki Referral Hospital, and also personal assistance to Chief Executive Officer of Moi Kibaki Referral Hospital. So I have over 10 years experience in nutrition and dietetics. Apart from the practice, I also do private practice at a nutritional consultancy firm called NutriQuest. I also lecture nutrition and dietetics with Nutrition and Dietetics Academy, having produced almost 4 cohorts of nutrition oncology specialists for the last 4 years. I'm a husband to 1 wife and a father to 1 beautiful girl. And I'm a born-again Christian. I love Jesus as my Lord and Savior. So for all that background and introduction, I want to welcome all of you. I know we might not have time to do introduction, but for these 2 days, I hope that we are going to really enjoy the series of what esophageal cancer is and nutritional management. And I hope I'll be glad to meet your expectations. All right, so the reason why I chose this topic is because of we've done some series before. We've looked at some topics on nutrition and cancer. And I feel like esophageal cancer is one of the quite rising cancers in Kenya, and it is a cancer of note to look into. So I feel it is important for us to start the year with this series. Of course, I want to welcome you to other series that will be running towards the year. And I hope you'll be able to learn a lot out of it. And now that you've been persistent client, I feel next series I'll have a bonus for you. You can either pay for the next series, and I'll even consider some as just free, so that you can learn, because again, you people have been very consistent and other people. So today's topic will really try to look at more of a background. I hope my slides are okay. You can see I'm at slide number 1, esophageal cancer and nutrition indication. Kindly confirm that you can see that. So then we can move. Perfect. Great. All right. So also our outline of this presentation, it will be a 2-day series. Today I'll cover much of the technical part, which is the looking at just on the esophageal cancer. We look at the structure of esophagus. What is this esophagus? Looking at it, what is its function, and how does it lay out. We look then now in terms of esophageal cancer. So my presentation will cover anatomical structure of esophagus and the digestion function. We look at what we call pathophysiology of malnutrition in esophageal cancer patients. We look at how in pathophysiology, in simple terms, we look at how cancer of the esophagus leads to malnutrition. And at the same times, we'll also try to look at how malnutrition can lead to cancer of esophagus. Then, of course, we look at the nutritional assessments that are needed for cancer patient, esophageal cancer patients. We look at common nutritional complications that these patients experience, nutrition indications and interventions. Especially, we look at the surgical part, the chemotherapy, and palliative care therapy. So, most esophageal cancer patients go through these three stages. So, we'll try to look at each stage and what nutritional intervention to do. So, looking at an esophagus, the diagram you are seeing in your screen is just a structure of a gastrointestinal tract uh, system. So, of course, we understand that digestion starts from the mouth through the process of chewing and cutting, that is through the use of mouth and tongue, where we also produce some enzymes here, salivary amylase, which start breaking the bond of carbohydrates before they go to the stomach for further digestion. So this structure just shows you the structure of anatomical structure of gastrointestinal tract. Of course, we have the mouth, we have the salivary gland, which plays a bigger role because it reduces what we call salivary amylase, a special enzyme that helps in digestion of carbohydrate. Then, of course, we have so salivary gland. We have the one that is in the sublingual area and also the one in the maxillary area. So, as you can see there. Then, of course, we have salivary gland also in the parotid area. So we have them quite spaced in the head circumference. Then, of course, now the pipe that connects the mouth um, to the stomach is what we call as esophagus. So this is what we call esophagus. So as you can see, it's just like a channel that the food uses, like a pipe that food passes to get into the stomach. Then, of course, we have the liver here, and of course, we have the stomach here. We have the pancreas. These are all play key roles in matters digestion, the gallbladder, the small intestine, the appendix, which does not have any digestive functions. But again, it is also very important. You find most of the waste that you get in food get settled here, especially the metals. Of course, we have the caecum, and of course, we have the colon, which is the part of the large intestine. We have the rectum and the anal region or the anus. So this is basically how the anatomy looks like. But important to note is where the esophagus is positioned. So if you dissect a human being into two, then you'll be opened to this kind of structure. And so the esophagus is what we are going to discuss this part here. So internally, if we open the esophagus, this is what you'll find. So, so we've dissected the pipe inside now. So let me just go back. So this part here is what we've dissected into two, just to look at the inside part of it. So here we'll have quite so much to look into. So of course, this is the structure of course of the mouth, the inside of it. So we find the esophagus is somewhere here. Inside of this also we have the tongue. Of course, now we try to open the inside of the gastrointestinal tract to look at some finer details. Of important to notice that we have other organs that are adjacent to esophagus, and in because we are discussing cancer here, they are also at risk of being invaded by the tumor that is at the esophagus, like the hypopharynx, oropharynx, and nasopharynx. So you can find the tumor going upwards. These are also squamous cells, so they are able to be contracted by the cancer. So let's discuss something on what is this esophagus in details in terms of the anatomical structure and its function. So, of course, once the bolus of food passes through the oral and laropharynx, what we've just looked into. So, once the food has passed through the nasopharynx and also the oropharynx, as you can see, it goes down to the esophagus. So, nasopharynx mostly when we are feeding through a tube. So it enters the esophagus. This is a muscular tube located behind the windpipe, and collapses when empty. So when there is no food, the esophagus collapse, but it is just behind the windpipe. And sometimes when you are feeding and the food passes, uh, get into the windpipe, you find somebody choking because the food gets in. The windpipe is where the gas direct to the lungs. And even when we are inserting a gastrointestinal tube, sometimes when it doesn't go through the esophagus and it goes through the windpipe, you find the patient having aspiration challenges. So in terms of the length, esophagus is about 10 inches long, and it starts from the bottom of the laryngopharynx and ends at the opening of the stomach called the cardiac sphincter. So maybe if I take you back, so this is the pharynx we are talking about. So esophagus, it starts from the laryngopharynx is just the whole of this. This is the laryngeal. So this face part here. So it starts from our top here, from the mouth going down onto the stomach. So when we go back to the first diagram, we are looking at start from somewhere here, and then it goes up to somewhere here. So it is quite a long stretch, 10 inches in shape. So it ends at a stomach called the cardiac sphincter. So cardiac sphincter is that this part here where it connects the stomach is what we call the cardiac sphincter. Then, of course, a sphincter is a circular arrangement of muscle, usually smooth muscle cells, that is used to open or close a tube. Okay. Are we together? Are you people following up my conversation? I need to see that I have not lost most of you here. I'm taking you back to your classes. Some it's their first time, so it is important that I we are on the same page. Okay, good. I can see that people are quite following up. If you are not following, kindly alert me so then I can do some repetition. I like taking people step by step for them to get into. So why I've started with this background, because this is going to form our serious conversation as we are looking at esophageal cancer in details. So here, this sphincter loosely controls entry into the stomach. The esophagus passes through diaphragm located just above the stomach. So diaphragm is just passed through it above the stomach. This muscle assists the cardiac sphincter in limiting access to the stomach. Then, of course, esophagus has four layers. So, when we're talking about esophagus, it is in four layers. The one that you could see is just the pipe, but inside the pipe, there are layers that have been aligned. So we have the epithelial lining, which is made up of stratified squamous cells. This is the most area that is most majorly attacked by cancer cells, as in the mouth and the pharynx. So you can find that the cells that are found in the esophagus and the pharynx are the same, and that's why I was saying it is possible that you'll find that the cancer of the esophagus can spread up to the mouth and also the pharynx. So it is important. So we are saying that that epithelial lining, then of course the mucosa and submucosa of the esophagus folds along the length of the tube when it is empty. So the muscularis has two layers of muscles. So when you talk about muscularis, this is just the muscles, the type of muscles that are within the esophagus. So we have the two layers of muscle, the inner circular and the outer longitudinal, but not all of muscle is the same type. So if I go back to it, the outer one is the outer muscles that cover the esophagus is the outer one. Then there is an inner one that we call the inner circular one. So the first third of esophagus has skeletal muscles in the muscularis layer, and the last third has smooth muscle, and the middle portion has a mixture that gradually goes from skeletal to smooth muscles. So why this information is important is because when we are going to look at some of the risk factors of esophageal cancer, you'll find things like alcohol, smoking, which mostly affect the smooth muscles of the esophagus. So you'll find most of where the tumor will be, it will be at around the middle portion where we have that the last third layer. Then the esophagus has also what we call adventitia that blends the tube covering with the surrounding tissue and holds the esophagus in place in the throat. So adventitia is basically a muscles that be able to hold the esophagus in the throat. So that is more about anatomical structure. So what we were talking about is, as you can see here, so we have the diaphragm here, and you can see esophagus has passed through it in the outer part. So we have the outer side, which we call the serosa adventitia, present only inferior to diaphragm. And then, of course, we have the external muscle layer. So external muscle layer, we have the outer longitudinal layer and inner circular layer. So the inner circular layer that we were talking about is this one we are seeing. Then, of course, we have the submucosa. Then we have the blood vessels. We have the mucosa muscularis, mucosae. We have lamella propria and epithelium. I want you to take note of this diagram, because when we are going to look at the staging for esophageal cancer, it is important to note that these structures are going to be attacked when the tumor is penetrating at the esophageal region. And why is also this important is because you can see this hollow channel here. When the tumor comes in, it will penetrate deep inside and close this part, so the food might not pass from the mouth. So that's why this part is very important for you to learn. So when you're talking about a patient with esophageal cancer, you imagine a scenario where the tumor goes from outside and it penetrates deeper into these tissues and be able to cause a blockage. So we'll also be discussing some what we call dysphagia, which is difficulty in swallowing. It is also comes in levels, and that is orchestrated by the tumor itself. So let us look at the process of swallowing. This is very important because it will help us to understand the aspect of when the tumor is there, what really happens. So let's look at the process of swallowing and how this is linked. So swallowing is actually a complex process. When a person swallows, a series of reflexes occur that ensure that the action occurs properly. So you might think that you can swallow and that it is an easy process, but I can tell you for a fact that it is a series of processes. It's a very complex processes. First, the soft palate rises to close the connection with the nasal passage. Remember, we said that the esophagus is just behind the windpipe. So when we are swallowing, it means that the soft palate will be able to close the windpipe, which is the nasal passage, to allow the food to pass. Okay. Then the tongue blocks the possibility of re-entry of the food into the mouth. So that is the tongue, as simple as you can see it. It is very important in its function that once the food has already gone, it prevents re-entry of food back. The larynx rises, causing a lid-shaped piece of cartilage and soft tissue called the epiglottis to cover the opening to the trachea, closing off the windpipe. Now you see. So that's why when the windpipe is not closed and the food passes by, you find this many of patients choke and they have quite irritations. And I know some of you in one way or the other. Let me confirm from Faith Jahira. Have you ever been in a situation where the food has passed and gotten into your windpipe when you are eating?
Yes,
How was the experience?
I saw heaven. Anyway, it was a bit shocking, but yeah.
Yeah, it's quite unpleasant kind of experience, isn't it? Yeah, so that's why the process of swallowing is very, very important to understand. So then you understand what really happens when now the food bypasses into the windpipe. So the presence of food in the esophagus stretches the tube and causes the muscle contraction that results in what we call peristalsis. So peristalsis is just by the force by which the food goes down. So solid food passes to the stomach in 4 to 8 seconds, liquids in 1 to 2 seconds. So that's why it is easy for liquid to go very fast, but solid food take like 4 to 8 seconds from the mouth to the stomach. So you can see that really esophagus is just but a passage. So the food does not take long. It doesn't have any digestive functions apart from allowing a passage that connects the mouth to the stomach. So for solid food, it takes like 4 to 8 seconds before the food steps in. So for example, if you just take ugali right now from the mouth, you swallow, it will be you count 1, 2, 3, 4 up to 8, it will be there. Then for liquid it's just 2 seconds maximum. So when food is swallowed, the bolus of food no longer resemble what has been eaten, That is very important information. The nutrients have been partly digested but are still not ready to be absorbed into the body. So you need to understand that once you've taken ugali, the bolus will not be the same form that it is, because remember, digestion partially started in the mouth. So further digestion is necessary and will continue in the stomach and small intestine. So today I just want us to focus on the esophagus and swallowing. So basically that is what swallowing process is all about. So this is the descriptions of what we are talking about. So you've eaten your food here, bolus of food. So we have the pharynx here. We have the tongue, which we are said is prevent the food from coming back. Once the food has passed here, the food prevent the food from coming back. Then, of course, we have the epiglottis. So epiglottis is the one that will be able to close and prevent the food from getting into the windpipe through the trachea, into the trachea through the windpipe. Then, of course, we have the esophagus. So the food has to go through this, has to pass there and avoid getting into this part here. Of course, when the epiglottis is not closed, that means the food will go through the windpipe and also to the trachea and into the lungs. So this is the process by which swallowing process occurs. So then after here, the food now through the esophagus, we have constriction and peristaltic force. So what esophagus does, it's like it does kind of a relaxation and contracting. So when that happens, there is a force that pushes the food from the up going down. It's not like it is a static pipe, but it is able to relax. The muscles of the esophagus are able to relax and contract, and thus it's what we call peristalsis. So it constricts and also relaxes, so the food gets into the stomach and to this. So this is how the food gets shortening and also relaxation. Good. So having understood very well the structure of esophagus, I think we can now proceed and now discuss the esophageal cancer and details. Do you all agree? Can we move forward? Or is there a question that somebody might have to ask before we proceed? Great. I have a quite bright students in here. It's good to have you people who are so sharp and have gotten it within the first trial. All right, so let's look at esophageal cancer now in details. So looking first, before we look into esophageal cancer, I put up this slide so then you can look at the cancer statistics currently in Kenya, where we are. So in terms of incident, breast cancer is still leading at with 40.8% in terms of incidence, with mortality of 19.6%. Then number two is prostate with 39.7%, with the highest mortality in Kenya. So the leading cancer mortality is in prostate cancer with 24.4%. Cervical uterine is 32.8% in terms of incidences and 21.4%. It is important to note that esophageal cancer, which is cancer of the esophagus, is number 4 in the line, and it is the incidences rate. This statistic is for 2022. I know tomorrow we have World Cancer Day, and we'll have new statistics coming up with the National Cancer Institute giving us the new statistics. These figures could change by tomorrow. So esophagus is number 4 currently, with the looking at it with 13% in terms of incident and 12.4%. Then, of course, we have colorectal, following up ovarian, stomach, and all other cancers. So this is how our cancer landscape looks like. And I felt that it is important for you really to have this slide with you because it will help you as we move forward in our discussion. So we are saying that in Kenya, cancer is the third leading cause of death after infectious and cardiovascular diseases. The annual incidence of cancer was estimated at 44,726 cases with annual mortality of 29. So you'll find that both the mortality and morbidity are almost half. So among men, prostate, esophageal, and colorectal are the leading cancers, while women, breast, cervical, esophageal cancer are most common. The leading cause of cancer death in Kenya is prostate, followed by cervical, and then breast. So I wanted to give you that background. So then when we move forward, it is important that we look at where esophageal cancer is. So let's narrow down to esophageal cancer, and we are saying that it's the 11th most common cancer and 7th most frequent cause of mortality in the world. So looking at the world statistics, esophageal cancer is the 11th most common. But now when we come to Kenya, it is number 4 in terms of incidence. Then, of course, number 3 in terms of mortality. So those are very important statistics for you to really look into. That when we're looking at the global incident, you'll find that esophageal cancer is really number 11. And then, of course, the 7th most mortality in terms of mortality. So these are global statistics in 2022. Then in Kenya, it is one of the top 5 cancers in both men and women. In addition, cancer has been reported to be on the rise, in particular hotspots in the country. And we look into that as we go by. So the main variant of esophageal cancer seen in Kenya is esophageal squamous cell carcinoma, unlike in Europe and Asia. So in Kenya, we are having quite a typical different types of esophageal cancer in terms of the cells that are affected when you compare this with Europe and Asian continents. Currently, international screening guidelines for esophageal cancer do not exist. Unfortunately, we don't have any screening for esophageal cancer. However, due to the high disease burden in Kenya, there is a need to provide guidance on how to improve early diagnosis of esophageal cancer. This can lead to a better treatment outcomes, better prognosis, and will be more cost-effective approach as compared to current status, whereby late diagnosis is the most common. So unfortunately, you find majority of cases being that they are presenting to the hospital at late stage disease, which is quite unfortunate. The reason is compared to like cervical cancer and breast cancer, which currently have screening, for esophageal cancer, we still don't have any screening modality. So there are two main subtypes of esophageal cancer. We have squamous cell carcinoma, which we've said is the most common one in Kenya region. Then adenocarcinoma, which account for 90% of esophageal cancers in Kenya. So both squamous cells and adenocarcinomas, these are just, when we talk about squamous cell carcinoma, these are just the cell that originate from the glandular form and the adenocarcinoma. So they are most of esophageal cancer are either categorized as squamous cell carcinoma or adenocarcinomas. And they account for 90% of esophageal cases in Kenya. Are we working together up to that point? Is it making sense? I'd like to see your reactions. If you're still with me or I've lost you. Lydia Simiyu, tuko salama, tunaendelea vizuri?
Yes, Mr. Kinda,
Yes,
we're
we're
okay. I'm
following.
okay.
Great. Now it's okay. All right, so let's look at some of the risk factors of esophageal cancer. What is it that causes esophageal cancer? I know I was to do deeper breakdown, but because of time, I might not be able to look at each risk factor in details. But allow me just to take you through some of the risk factors that we have. The first one is called I'm looking for some slide that I want to explain very well. So the first one is alcohol intake. This is one of I can tell you, the key most common type of cause of esophageal cancer. I can tell you, Esther Achar, that indeed many Kenyans, both genders, do take serious alcohol. Right now, again, statistically speaking, when you go to joints, you find majority of female gender have really overtaken their male counterpart in terms of alcohol intake. Faith Jahira, I don't know if you've experienced this too. Have you noticed it of late? What is happening?
I do not have a short answer for that question. Yeah.
Okay, Daisy, what is happening right now? You've observed. I'm not saying you visit those areas. Might you be having an answer to that? Faith Joseph, I would like to hear you. It's good that I have ladies in this space. Esther, go ahead.
I think, Dr. that's true. That's because even within some of the patients also that I've seen, women are really struggling with issues of the drinking, and also smoking. I mean, so it's a trend that is on the rise. Probably maybe due to stress levels. I don't know. Thank
Women
you.
are getting more stressed than men.
I think so. I think so. That's a
Okay,
debate
quite
for another day.
a debate for another day. I think this is a research platform that we can explore. What do you think, ladies? We can come together and do some good studies and see, find out what is happening, and then of course look at health-seeking behaviors for them. So so let me take some few minutes in time to describe how alcohol affects esophagus and how it leads to esophageal cancer. We are saying that, however, even those with a moderate consumption, like let's say 2 drinks per day, made up 14% of alcohol-related cancer. So apart from esophagus, many cancers are known to be caused by alcohol intake. Alcohol has been directly linked to at least 7 types of cancers. We have mouth and upper throat, larynx, esophagus, breast, liver, and bowel cancers. All those cancers have been directly linked with alcohol intake. And there is a correlation between the amount of alcohol consumed and the increased risk of developing cancer. And there is no threshold. So when you are advising a client who is in serious alcohol intake, of course, we have the program that they need to go through in terms of withdrawal, step by step. But at the ultimate gain, as a healthcare provider, your aim is for them to stop completely because there is a direct linkage. You look at it of esophageal cancer, please, you can advise them. So there are some statistics in Europe alone. 80,000, more than 80,000 people died from alcohol attributable cancer in 2016, equivalent to 1.9 million years of life lost due to disability or premature mortality. Looking at worldwide incidence, it is estimated that alcohol is the cause of more than 3 million deaths each year, of which more than 400,000 are from cancer. So there is no huge debate about this. Alcohol has direct linkage with esophageal cancer, and it is one of the main cause. If I could have had time, I could have taken you through the deeper part of this alcohol, but allow me just to give you that briefing because as time will allow us, as we move forward, we'll be able to really dwell deeper into alcohol and esophageal cancer. But one thing you need to note is that indeed esophageal cancer has a direct cause. Alcohol has a direct cause for esophageal cancer. The second thing that we have to look into is the family history of esophageal cancer. Of course, now looking at the tree line of esophageal cancer. So if we have paternal and maternal side where there is a history of esophageal cancer, then of course we anticipate that will happen. Age is also another factor. There is risk from 45 to 70 years. But again, I need to put a rider here that right now the statistics are shifting in terms of age. Majority of cases we are seeing right now, because I'm currently doing a study on esophageal cancer and nutritional care, majority that we are currently seeing are young people, majorly those who are in chewing mirror at the same time they're doing alcohol. So we are looking at the cases not and the traditional of 45 to 70 years. Then of course male are more predominant because of course the health seeking behaviors, their dietary practices are poor. The majority of men smoke, majority of men take alcohol, some do mirror and all that. Smoking history is also another issue. This one I can't even overemphasize on it. Tobacco smoking also has been directly linked with esophageal cancer. So uh, for smoking, it's not even a matter of either we are looking at the matter of reducing or anything else. The best we can just do is just to advise the patients to stop smoking. Again, I need to also mention this that right now we are looking at trends where you find that there are those who are not smoking, but they are close to people who are smoking. We term them secondary smokers. So those people are also at risk. And I can tell you for a fact, Faith Joseph, that right now, even in clubs and where we have revelings, Apart from the smoking of cigarette, there's a shisha smoking. Another worrying trend. Right now, we are evolving. And then, of course, we have what we call smokeless tobacco. All those, as long as we are talking about tobacco, then that means we are looking at the aspect of esophageal cancer. The main ingredients that are in tobacco that is of concern is the nicotine, which affects the mucosal lining of the esophagus. So what we are saying is that both alcohol, both smoking, male gender are also the risk factors. Then overweight and obesity. So you'll find somebody who do not smoke, who do not take alcohol, but they are overweight and they are obese. That again pushes the pressure. So how is the correlation? When somebody is overweight or obese, what happens is that you might have what you call the outpouching of the stomach. In medical terms, we term it as hiatal hernia, where now the stomach is able to pass through the cardiac sphincter, the one that we've just discussed, and now the food content is able to come up. So that is what obesity does, and that is what being overweight has more highly linked. Of course, apart from that modality, obesity has been highly linked up with esophageal cancer and other types of cancer and cardiometabolic diseases. Then, of course, now of interest to note is that there's also carbon exposure from firewood and other sources. Another important conversation. So you find that majority of our mothers or in the traditional setup, they use the carbon exposure when they are preparing food. Esther, you'll agree with me that this is quite common, especially in the villages when they are cooking. It's one of the things that happening. Then you find the house being poorly ventilated. So it is indeed something that also should be looked into. So then, of course, we have the aspect of Barrett's esophagus. So Barrett's esophagus is just a syndrome. It's the presentation of the esophagus where you find that the esophageal lining is more exposed. This is a medical condition where the lining that protects the esophagus is more exposed. Remember, the esophagus itself on the gastrointestinal tract is protected by what we call a mucus lining. It's like it protects a thickness that protects the lining of the stomach and the esophagus. So I've seen Esther ask some important question here that we need to handle. That how about people who shout a lot and strain their vocals, each pastor, singers, is there any risk? Not necessarily. Remember, what we are looking into, any item that is going to corrode the lining of the esophagus, that is what it's more is going to cause more problem. So such people maybe, which I don't think is the case, is they're looking at the throat cancer and all focal cancers, but not the esophagus per se. Remember, esophagus is really disconnected from the voice itself. So any product or any item that is going to affect the mucosal lining, the lining of the esophagus. Let me go back and just demonstrate, show you something what I'm talking about, so then you can connect. Anything that is going to affect the lining here uh, and corrode it, make it vulnerable to hot foods, to everything. That is the most common. That is what we term. Now, other than the risk factors that have listed here, I need also to add some. Like now, we have studies that currently have been done on Mursik. I have prepared a presentation on this. Mursik, it's a challenging drink. Hot tea, it's also something that we need to add here. We have chewing of miraa, very studied, and we have quite statistics that have shown that indeed that is it. So hot tea, what does it do? So what happens is that we have, as I've mentioned, that the esophagus lining is protected by a mucous membrane. So what happens is that when you periodically or occasionally take hot tea or frequently take hot tea, then it affects that mucosal lining and expose the esophagus lining, and therefore make it vulnerable to other infections, causing an ulcer. Then, of course, Mursik, as we look into, there are studies that have shown that, and I'm going to take you step by step on how that has been linked up. Mira has also been able to be demonstrated to show that. So we are currently starting to see high numbers of esophageal cancer in the western region, especially and Rift Valley, and also going to the northeastern part where many people chew Mira, and also the Meru and Embu side. So let us discuss something when we are on esophagus in terms of the Mira and the region. So, esophageal carcinoma is highly prevalent in Western Kenya, especially among members of Kalenjin community who reside in northern and southern areas of Rift Valley. So, studies have proven that indeed, in the northern and southern part of Rift, we have had quite a number of increase in terms of esophageal cancer. So 5-year data from Eldoret Cancer Registry regarding cancer prevalence in Washington County alone, an area inhabited by mainly Kalenjin, shows esophageal cancer to be the most common cancer. It is the most prevalent among men, followed by leukemia and prostate, whereas it is the third most common in women after cervix and breast. So this one we are looking at now, the Rift Valley region. Why is this so important? We are going to look at those factors. So the environmental factors that have been suggested include contamination of food by mycotoxins and or pesticides. So one of the reasons why there is higher reported cases of esophageal cancer in those regions is because majority of them use pesticides, especially in the tea farms, in the maize farms, and also in their agricultural products. That has been directly linked to that because the pesticides have what we call mycotoxins. Then, of course, consumption of traditional alcohol, locally referred to as busa and changa. This again applies heavily on the western part. I don't know. Maybe let's hear from Lydia Simiyu. How frequent is it? I know you are from those area, and Bungoma County is within Western. Would you like to comment on this?
Oh, okay. Mr. Wakinda, you're not lying, actually. It's true. The data, actually, where I come from, I'm from Bungoma, and we have a high rise of cases of esophageal cancer in our place, and it's something to look into. Thank you.
Ah, great. So I know looking at the traditional practices, Busa is one of the main thing that is involved in the aspect of traditional activity. It's one of the key component item that is integrated in the tradition. Is that true, Lydia? Busa and
Yes, it's very true. Yeah, it's very true. Actually, the commonest thing about our patients that we're receiving, they come
Mm.
from low social income places. Then the majority they are the local brewers. So it could be true, actually.
Okay. All right. Quite interesting to note. So indeed, in studies have really proven. Then, of course, now use of fermented milk, mursik. We are going to look into this also in details. Then poor diet. So you find somebody who takes traditional alcohol, majorly they don't take it well, so they experience poor diet, tobacco use, and genetic predisposition. So let's look at something on traditional fermented milk or mursik. I know we'll not only focus this on the Rift Valley alone. I know even the likes of Esther. Esther, do you guys do we still have chuck on those areas? Chuck. No, those Adila and everything. Esther, I don't know if you have experience
Uh,
on this.
yes, I think there still is,
Hmm.
but mimi nimelelewa town kidogo, lakini when we go to shags, sometimes I hear, people talking about that. So there is
Aha.
that still as well. Yeah.
Exactly. Yeah. So me growing up in my village, this was very common. So of course, when you had cows, we were rearing them, and this, I think it's still a practice right now, where now the milk is stored in a gourd for some time. Then of course it's be prepared to have fermented milk. But now, Us, we never used to add anything on it. But now let's look at the one for the Rift Valley and see why it is quite linked up with the esophageal cancer. I hope you are following up, and even if we will have to stop today, I don't have so much speed to finish up this topic. I want you people to absorb and learn because I know you are going to be advocates in different places that you are going to be. So I'll kindly allow me just to take you step by step because I can as well rush and you miss a lot of things. So let's look at something on Mursik. Fermented milk is part and parcel of Kalenjin culture and is usually drunk after every meal. Some have hypothesized that there are world-class athletic prowess associated with the use of Mursik. So indeed, we all agree that we've seen how our athletes does well, and majorly it has been hypothesized, though there are no studies that have confirmed that our athlete progresses because of Mursik, but it is believed, it's a belief system. Its preparation process involves the use of a gourd, what we call sautet, and a bowl-shaped stick, sociot, usually from palm trees, and charcoal from selected trees and shrubs, which is also called suteio. The commonest being Senna didymobatra, Juniparis procera, and these are just the names, the scientific names of those palm trees that are being used, and wild tree. So these are just the commonest that is being used. So the sticks are used to grid embers of charcoal by pressing against the walls of the guard in methodological circular in and out movement of the hand until the inside of the guard is evenly covered with fine dust. So this is just the process. Then boiled milk is then poured into the guard and allowed to ferment in cool, dry conditions. If a new guard is used, then it has to be fat sweetened in order to remove the bitter taste. This is done by the use of fresh bark from either Ozoria insignias. These are just the type of bark of the trees that they use. The bark is placed inside the gourd, which is then filled with water and left to cure for 3 days. So this is just the process of how mursik is prepared. Now, we are linking up mursik. Don't lose the concept here. We are linking up mursik and esophageal cancer. Now, from the literature, the publications that link this mainly uh, relate to the presence of what we call acetaldehyde. This acetaldehyde is also present in alcohol. It's a carcinogenic substance in soy milk and other contaminants as a result of poor processing. So I want to clarify that it is not really the mursik itself that has capability of causing cancer, but it's the preparation, as you've seen the steps that the mursik goes through. So what we are producing is is what we call acetaldehyde, and acetaldehyde is what affects corrode the mucosal lining of the esophagus, and therefore exposing it to carcinogens and therefore cancer of the esophagus. So the most plausible association between mursik and esophageal cancer or esophageal squamous cell carcinoma will therefore emanate from mursik containing mycotoxins originating from contaminated animal feeds, which will act synergetically with acetaldehyde present in fermented milk. So this is the correlation that the method by which mursik is prepared has a higher link of it causing esophageal cancer. Has that gotten well with you? Have you learned something out of it? Do you now have a reason to advise correctly? Faith Joseph, how are you? Are you hearing? Yes, Faith.
Yes,
Are you following?
yes, I am.
Okay. Are you learning something out of it? Oh, great. All right, so let's move on. So, having studied the risk factors, I know there are so many, and I could have taken longer time to expand that, but I know because of the limited time we have, let's just move on. So, let's look at signs and symptoms. What are some of the signs and symptoms that somebody will start presenting with that you really need to start being worried? So we have the first one is called dysphagia. So esophageal cancer presents itself from what we call difficulty in swallowing, and that is termed as dysphagia. So that is how it all starts. So somebody start experiencing difficulty in swallowing. Many at times it starts with just a mild feeling as you swallow food, and then it goes on and on as we proceed. So difficulty in swallowing is one of the main signs and symptoms that we experience. It's called dysphagia as a medical term, and it has stages. We have, I mean, grades. We have grade 1 up to grade 4. So grade 1, you'll find that solid foods are passing, but with slight difficulty. Grade 2, now you can't talking about semi-solid. And then, of course, now grade 3, you're talking about soft diet. And then, of course, the last grade, you find that even the water, you'll have challenge even with the water, even saliva passing. Then, of course, we have what we call odinophagia, which is painful swallowing. It's also another thing that the patient start experience. Somebody start experiencing that. So it is something that also you need to consider. Then a gastrointestinal tract bleeding with hematesis or melanoma stools. So you find that sometimes somebody goes to the for long call and they have stool. It means that there is an internal bleeding that is happening. So when their stool is blackish in color, and then of course there's a blood, then it tells you there's something that is going on. Then of course we have recurrent aspiration or emesis. So you find these are people that after they have eaten, the food comes out, so they experience that. Postprandial vomiting, this happens after they have eaten, they start vomiting. They experience weight loss, which is quite progressive. So you find that within the last 3 months, they have lost some weight. Within the last 6 months, they have dropped weight. So when you're taking their history, those are questions you need to ask. Some might not remember their exact weight, but now the best way to ask this is to are there clothes that they no longer fit in well, that they used to fit in correctly. So those are some of the things. Then, of course, loss of appetite. And then we have also have what we call retrosternal pain. This is a pain that is within the sternum region. So they'll experience that kind of pain. So these are some of the signs and symptoms that majority of people experience before they are diagnosed with esophageal cancer. As I've said, there are other symptoms which also include heartburn, which is not responding to treatment. Majority of Kenyans right now are on this drug called omeprazole. It's a proton pump inhibitor. Its role is to reduce the amount of acid. So it is one of the most commonest drug that are misused. Anybody right now can go over the counter and take up omeprazole. So it is one of the things that have been linked up to cause the problem. So we have heartburn, which is not responding to treatment. I've talked about hoarseness also is important. Hoarseness of voice can be another issue. Generalized weakness, cough that is not improving on medication. Even if you give medication, it's not improving. Epigastric pain, all that are some of the signs and symptoms. So what do you do? So after you've taken a history and you find these are the signs and symptoms, now we go to the investigation. And investigation, now we look at the aspect of now upper gastrointestinal tract uh, endoscopy. So upper gastrointestinal tract endoscopy with biopsies, multiple suspected sites recommended is the investigation of choice. So what happens is that you recommend that patient to go for endoscopy. And in endoscopy, we are going to get some tissue for histology assessment. It is important to note that the cardinal diagnosis of cancer is through histology. You take a biopsy, you take it to the lab, then the pathologist will be able to tell you. So the cardinal diagnosis of cancer is through a biopsy. So that is very, very important to note. So for patients who experience who have experienced those symptoms, they are suspected. So what you do is basically you tell them for esophageal gastric endoscopy. If there is any what you call non-suspicious lesions, then you refer for appropriate treatment. So when you do a endoscopy and you find, when you find no suspicious lesion, you find there's no lesions or any ulcers that you see through endoscopy, then you can refer them for other treatment modalities. However, When you find in the endoscopy there are suspicious lesions, lesions are now there, you can find those ulcers, then you take a biopsy for histological examination. So that's why it is recommended that you take during the biopsy, you are able to take the patient also. I mean, during endoscopy, you take the patient for. The patient can also be done there, the biopsy. So in the histological examination, some of the things that you'll find is what we call low-grade dysplasia, moderate grade dysplasia, and high-grade dysplasia. So for the patients with low-grade dysplasia, you follow up every 3 years, and then if disease progression, then treatment changes. But now for those with moderate grade dysplasia, you need to take them for annual follow-up. Then for those with high grade, link to further management. So for patients who have high grade dysplasia, those are the patients you will have to link up for other treatment. It is important for us to note that. It is important for us to know that. So I'll be able to, before tomorrow, I'll be able to share with you the flowchart that can help guide you. You can use it in your care. Now, after you've taken your biopsy, they request for what you call immunohistochemistry. If World Health Organization poorly differentiated and undifferentiated carcinoma on biopsy, so you take them for immunohistochemistry for further analysis. Then other investigation is what we call barium swallow. If there's no obstruction where endoscopy is not available, you can do barium swallow. Investigation for staging, as I always mention and I keep mentioning, after you've done the histology and it has given you the feedback, either high grade dysplasia, then you need to take that patient for chest and abdominal scans or PET scan. This will help us in doing staging of the disease. Up to that point, are we together? Daisy? Daisy, are you following? In a place to talk?
Yes, I'm following.
Okay. So let's move. So now in the CT scan, you'll be able to find that now you basically looking at as it spread to the chest, as it went to the abdomen. Is there any distance metastasis? That is why we do the chest and abdominal CT scan for staging. Okay, so having done that, let's look at staging now. So now you hear in cancer, we have stage 1, stage 2, stage 3, stage 4, and all that. So it is important for you now who works and see this patient to understand which stage is it. Because it is important to note this, it will help you in terms of determining the best intervention to give the patient. So stage 1 or the first one that you'll have is what we call TIS, which in full is called carcinoma in situ. So this is just abdominal cells that haven't grown beyond the epithelium. And these are now you'll find the low-grade dysplasia. Then T1 is tumors have invaded the lamella propria, muscularis mucosae, or submucosa. So now I hope you understand this. You now understand these things. So we are talking about stage 1. We are saying stage 1, the tumors called them, they has affected the muscularis mucosae, lamella propria. These are just the internal muscles. So you can see this is the muscularis mucosae at lamella propria. So this is basically where the tumor has been able to invade. So that's why I started by taking you through that. Then, of course, now stage 1, we have them also classified into T1A and T1B. So T1A tumors have invaded the lamella propria and muscularis mucosae, while T1B tumors have invaded the submucosa. So if I take you back to our diagram, basically what we are talking about for T1, we are saying that T1A has affected the muscularis mucosae, while the submucosa, that is the part that you're seeing here, is with the T1B. Then, of course, T2, tumors have invaded the muscularis propria. T3, tumors have invaded the adventitia. These are the things we've learned. So let me go back and remind you of where adventitia is. So why I'm taking you through this, because now I don't want you to be in a position you are not able to understand. to understand the. I need you to be studying this. What is it called? The this reports that you are getting for histology, because now when you do that, it will help you in knowing how to do the intervention. I don't know. We've discussed aphasia somewhere. We don't have it in the diagram, so we can proceed. Let me not disturb you again. So we go. Then, of course, T4 tumors and invaded adjacent structures. So at the T4 now, we are looking at a disease that is already have invaded other structures. Like now, you're talking about the lungs. You're talking about other places like the abdomen and all that. So then, therefore, you are talking about T4. So T4 also we have T4A tumors have invaded adjacent structure, e.g. the outer lining of the lungs, pleura, heart pericardium, abdominal peritoneum, and or the diaphragm, and can be treated by surgery. So these are patients now you need to go for tumor excision. Then of course the T4B tumors have invaded other adjacent structures such as the aorta, the vertebral body, and the trachea. So that is how we do staging for esophagus. All right. So I know time is going up. If you allow me to just do the background of this, then of the nutritional part, then now tomorrow we can now get deeper into nutritional management, which is very key for us. So let's now link up the nutritional aspect and esophageal cancer. So patients with esophageal cancer report clusters of symptoms that can be related to poor nutrient intake. That is one. They experience serious poor nutrient intake because of course of the because of the aspect of dysphagia. This number two, they experience weight loss. We've talked about that. Declining physical function. When you do ECOG score, there's quite low, as well as fatigue, pain, depression. So majority of them, these are the things that they do experience, and it is a quite progressive. It might start slowly, but progressively it increases. So it is something that we need to pick at early phase. Such symptoms have also been associated with reduced quality of life and survival in patients with advanced diseases. In fact, there is a consistent association between symptoms, the presence of inflammatory markers, and an upregulated immune response. So it is important to note that yes, um, as as much as we are looking at the aspect of we've looked at the aspect of risk factors that could cause internally, there are so many things happening in the body of a human being, and that has been linked up with what we call the inflammatory markers. So it is important to note that as far as internally you might not see what happens, but majority of cancer, esophageal cancer patient and any other type of cancer, internally they are going through so much problems, and that has been linked with inflammatory markers and unregulated immune response. So poor cancer outcomes are predicted by markers of systemic inflammatory response, altered acute phase proteins. Daisy, Esther, Daisy, this is very important. Lydia, that this is the core of nutrition. If you get this right, you'll be fine. What we are talking about is that majority of cancer patients experience what we call systemic inflammatory response syndrome, acute phase. And during that phase, they have quite an elevated, okay? They have quite elevated uh, uh, needs for protein. So it is important that you note this. Why is this important? Because now you'll have to start intervening early by providing adequate protein intake at the earliest phase, whether those patients are well nourished or not. Please take note of that. Because when that happens, what we are talking about is that you'll have a positive nitrogen balance. Therefore, the body will not be using the reserve of proteins to build to fight the infection. So we are saying that poor cancer outcomes are predicted by markers of systemic inflammatory response altered by acute phase protein, elevated C-reactive protein, hypoalbuminemia, and their combination as Glasgow prognosis score. And changes in white cells count, elevated neutrophils count, low lymph node count, and all this. So these are some of the things that will tell you that somebody is going through what we call systemic inflammatory response issues. This is what we are talking about. So immune response, I've discussed this in several of my presentation and I keep really bringing it up. So we have natural killer cells, neutrophils and macrophages, inflammatory process happening here. We have anorexia, weight loss, fatigue, depression. All these are what is going to cause the nutritional problem for our patients. If you are not able to address this at early phase, you are missing it. You are going to miss it. You are going into cancer cachexia, and there's nothing that you can do about it. So, why is this conversation very important? It is important for us to note that one, if you manage to be linked to a cancer patient at early phase, whether they are symptomatic or not, as a nutritionist and dietitian, please, Lydia Simiyu, don't look at wow ni kapumpum or not. Internally, they are going through systemic inflammatory response process, and what that means is that they are using more protein to fight infection, and therefore they have little to be used for bodybuilding. So their immunity goes down. If you are able to provide adequate calories, adequate protein at this early phase, you'll prevent the extension of systemic inflammatory response process. And when that happens, therefore, you'll be able to help manage this patient at early phase. Failure to do this is where now we'll get into cancer cachexia, which again we'll look into in details here. So basically what happens is that the tumor itself releases inflammatory and other factors that affect the brain, the muscle, the liver, and fat function. Brain-altered appetite signals from the central nervous system cause anorexia, resulting in reduced calorie intake. Muscles, anabolic catabolic imbalance leads to muscle wasting, reducing muscle mass and strength and increasing fatigue. Liver, acute phase protein production is stimulated, repressing drug clearance and raising the risk for cancer treatment toxicity. Fat, energy stored in the fat deposit are depleted as cytokines stimulate increased lipolysis and cause defective lipogenesis, maladaptive and wasteful response to low food intake. So this is what we call the pathophysiology of malnutrition for cancer patients, especially esophagus that we're looking into. So we have tumor here. What tumor does is that the body itself will produce what we call a systemic inflammatory response. And when this happens, all these are going to have an effect on these organs. So when you're treating cancer patients, you need to have these organs in mind: the brain, the muscles, the liver, and the fat depletion. Once we reach the fat use and depletion, therefore you know that we are getting into cancer cachexia. Allow me to stop there for questions and answer. Tomorrow we discuss cancer cachexia and then nutritional assessment. We look at nutritional intervention for patients with the esophageal cancer. Any question? I'll be glad to take. Anybody with the question? I would like to get your 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 input. Thanks, Esther. Quite refreshing presentation. Thank you for that. Today, I just want to take you pole pole. Yes, Lydia, let's go. Take it up.
Okay, that was a good presentation, Mr. Kinda. But mine is a question about on the risk factors. There has been something that has been coming up very fast
Yes,
about the microbial contamination of food
yes,
and the water sources. There's something called arsenic in the water that is the article they're stating that it's directly that compound in the contaminated water around the water bodies that industrial effluent is not being treated. It's contributing to the esophageal cancer. I don't know how true is it because there is no enough information to say true. It's causing the esophageal cancer. I'm asking because where we are, we have the numbers of esophageal cancer that were coming from a certain area of an industry.
Okay.
If you ask someone where he's coming from, the person was just coming from that close to that place.
Mm-hmm. So there is a
So if you
pattern.
can, so yes, there is a pattern.
All right.
If you
Good.
can
That's
clarify on that, we
clarifying.
appreciate it. Okay.
Good. So, so yes, there are literatures have, and there are some publications that have linked up the chemicals with potential development of several types of cancer. The majority of them. Most of these reports, however, are based on what some evidence and are largely inconclusive, and sometimes require further studies. But of importance to note is that there is something we called, and I think I had mentioned it in the presentation of Mursik, we call it mycotoxin contamination. So what this basically means is that this has been largely associated with the either the from the companies there is effluent that are going into the drainage into the uh, chemicals from the company to the water bodies, or also associated with the delay and poor harvesting methods in terms of the region where they're doing the what is it called? The agriculture. So mycotoxins have also been detected in food, including meat, milk, eggs, as well as traditional beer. So what happens is that when the people that are staying around that area, apart from the river, the water body they're using, if they are the water source they're using is going directly to the farm and used for irrigation, then we are going to experience mycotoxins in those food products, and that can be linked up. So this has been attributable to mostly contaminated livestock feeds and maize flour used in fermentation, and even up to the aspect of OSA. So the mycotoxic have been linked up. So I think from your discussion, yes, it is true. There's affluent that is getting from the factory to the rivers and also to the farms. The water from these rivers are used in the farms, and therefore the plants and the crops are obtaining this, and then the humans are taking this. So I can tell you for a fact that that can be one of the things that we need to look into. But yes, they have direct link up. Now, mode of action, how do this work? So basically, just like any other action, when we take this food with the chemical itself, it corrodes the mucosal lining of the esophagus, exposing it to other components like the hot tea, uh, which causes ulcers. When that happens, we have Helicobacter bacteria residing there, causing more tumor. So that is basically what happens. So the chemicals that we are taking from those foods and from the factory, what they do is that they have the ability to get they have the ability to get into to affect the mucosal lining of the stomach, and therefore they can affect. So I might not really confirm completely, but I tell you for a fact that is something that can happen.
Thank you.
You're welcome. Like to get some more questions from you people. As we learn, as we wind up for day one, I know quite a number of things we've covered, and it's good to see how tomorrow we roll up. Yes, Faith, go ahead.
Yes. On risk factors,
Yes.
I haven't understood how overweight and obesity is related to esophageal cancer.
Okay, good.
Please
That's
elaborate on that. Two,
uh-huh.
I don't know whether the myth how scientifically is it proven about the hot foods and hot food. How are they related with the esophageal cancer?
Hot foods and hot beverages, isn't it?
Yes, yes, yes. I would like to know.
Ah, great. No, no, no. It is good question that you are asking. So let's start with the last question. So what happens when you take severely hot foods, especially those who are staying in cold areas for quite a long period of time? What happens is that when you continually is exposed to hot beverages and hot food because of the cold, trying to warm the body, you are the exposure of the hot food to the or to the of the hot beverages to the also to mucosal lining of the esophagus corrode the mucous membrane. Remember, I've said the esophagus is protected by what we call a mucous membrane, which is a thick protective layer, just like any other gastrointestinal tract. So when you are continually exposed to corrosion, then it exposes you, and this has been linked. When the hot tea you continually take hot tea, then it means that you are corroding the mucosal membrane and the layer, and therefore this really is going to have a direct impact, exposing the muscles of the esophagus, and then now you can start having ulcers coming up. The moment the integrity of the esophagus is affected, then you are very rest assured that you are getting into the aspect of esophageal cancer. Then the second question that pertains to obesity, I can approach it in two ways. One, obese patients, what they experience is hypermetabolism, and this has an impact in terms of the production of what we call the free radicals. Free radicals are thus ions that are not metabolized. So what they do, they destroy the cells. They are uniodized cells. So they destroy the cells, especially now in the mucous membrane. And obesity and overweight has been caused with so many cardiometabolic conditions, which cancer includes in it. So when you are obese, it means that you have free ions which are not metabolized or iodized. So what happens? They go in destroying cells, especially the healthier cells, affecting the genetical mutation. The second aspect is that obese patients, because of the high abdominal obesity, truncal obesity, what happens is that they experience hernia, hiatal hernia mostly. Hernia affects the cardiac sphincter, the upper gastroesophageal reflux. So many patients experience what we call GERD, gastroesophageal reflux disease, because of the outpoaching of the stomach. So you find that the stomach content are now released, are coming back. There's a reflux coming back to the esophagus, and that corrodes the line. Remember, stomach is acidic, is highly acidic. So the foods from the stomach will corrode the mucosal lining of the esophagus, and that is how obesity is linked to it. Faith, has that really tried to get to answer you?
Yes.
Okay. All right. It has been a very interactive day one session. So, what to take home from this day one? I know tomorrow I'll do quite a number of uh, recaps, because I know some of us really joined late, and I know we'll have new team joining tomorrow. But also, don't worry, because we've done the recording for this session. What to take home from is that esophageal cancer now is the fourth most common type of cancer in Kenya in terms of the incidence, and in terms of mortality, it's now getting into number three. The second important thing to note is that some of the risk factors that have been studied and found to cause esophageal cancer include the following: one, alcohol intake; smoking; we also have the aspect of men having a higher rate compared to female gender, because of course we are looking into the aspect of the health seeking behavior and health practices. We've talked of overweight and obesity. We've also highlighted the aspect to look at the MURSIC. We've looked at the aspect of miraa, those who are chewing miraa. Hot beverages have been also been studied to look into it. Those who smoke tobacco, and remember smoking, we also now look into smokeless tobacco. We are also looking for those who are exposed secondarily, especially those who are staying with that somebody who is smoking in the house. Some cardinal signs of esophageal cancer that you need to note. One, you'll have the aspect of difficulty in swallowing, what we term medically as dysphagia, categorized into 4, where we have grade 1, grade 2, up to grade 4. The second is an intentional weight loss. The third one, you'll have hoarseness of voice. You'll have blood in stool, or your stool is dark in color. You'll have the aspect of the patient also having pain while swallowing. So those are some of the signs that you need to check. Very importantly, you also need to note that currently in Kenya and also worldwide, we don't have the screening modality for esophageal cancer. So we don't have any recommended screening for esophageal cancer. Again, it's also important to note that the esophagus does not have any critical role in terms of digestion apart from promoting what we call peristalsis, which is just the force by which the muscles of the esophagus relax and contract and allowing the free passage of food into the stomach. Again, we've also noted that the cardinal diagnosis of esophageal cancer requires you to do what we call gastrointestinal tract endoscopy with a biopsy. So when you do the biopsy, you'll be able to take the sample for immunohistochemistry or histology examination. And as any other cancer, the cardinal diagnosis of esophageal cancer is through biopsy. After you've done the biopsy, of course, there are some outcomes that you're going to expect in terms of the endoscopy. One of them, you'll find either low grade, moderate hyperplasia, moderate. You'll have low dysplasia, moderate dysplasia, and high grade dysplasia. So those are the estimated outcomes that you'll have in the endoscopy. Then, of course, we do the biopsy to check if we have any cancer affected. After that, we go to another stage where we do what we call staging. And I told you that staging, we can either use CT scan or PET scan. And in staging, you do the CT scan of the chest and CT scan of the abdomen. Then you'll be able to know whether the disease has spread to other organs. From that point, now it determines the treatment modality we are going to have. We've also looked at pathophysiology of nutrition, how malnutrition occurs for cancer patients, especially esophageal cancer. So that's said and done. We've wind up our day 1 presentation. Tomorrow we'll do some few recaps just to jog our mind. Then now we go deeper into treatment and then the nutritional assessment and nutritional intervention for patients with cancer of the esophagus. With that said and done, if we don't have any question, I allow us to end it from there, unless there's any question or anybody we've locked out. Elizabeth Mombasoi, how are you? I hope I've gotten your name right. You've joined us as we were just winding up.
I am so sorry. Dr. Mbogo forgot to send me the link. So he sent me very late. That's how I have come in late. But it's okay. Tomorrow I will try and join in good time.
No problem. Good to have you.
Thank you.
We also have recording, so we'll share just for you to have a recap.
Thank you. Thank you.
All right. All right, everybody. It's my pleasure to have all of you for day 1 session. Let's connect tomorrow. Same time from 7. The link is the same, so don't bother again. So kindly connect. If you have colleagues who can join, registration fee is 1,000. Those who can join tomorrow, if you have friends, they can just pay 500 shillings and then they can still join the session. So then we learn together. It's quite important to learn. Otherwise, thank you very much. God bless you. Have a lovely evening. See you tomorrow. Same time, same place.